have joined the room. So good afternoon, everyone. I want to thank you all for joining us for our first of this quarter, our first of the year ICONS call. So this call is developed with the Perinatal Quality Collaborative Vermont. And we wanted to let everyone know that we have recently rebranded the Improving Care for Opioid Exposed Newborn name for our project has now been expanded to address the increasing substance use in different formats in the state and in the country. So we will now remain the name ICON with an S on the end. And we have updated our name to Improving Care of Newborns with Substance Exposures. So you will see that as we move forward, but everything will remain in our website and in our quality improvement initiatives throughout the state with just a slightly different name. So thank you again to everyone for participating today. We have a huge team of experts and excellent participants today. And so we are today going to be discussing changing guidelines, updates on newborns' exposures to hepatitis C and HIV. We have several speakers today. So we have two of our wonderful faculty members here on ICONS joining us. So first, I'll introduce Adrienne Paul. And Adrienne Paul, as many of you know, is a neonatologist here at UVM Medical Center and has been involved with the PQC Vermont ICONS team. She works in both the neonatal intensive care unit and the high-risk infant follow-up clinic and has been faculty with us for several years. I'm very much interested in leading efforts around improving care of infants with neonatal opioid withdrawal syndrome, or NOWS. And then Dr. Molly Rideout, who has been with us for a bit longer here at PQC Vermont and ICONS. Dr. Rideout is a pediatrician and newborn hospitalist at the UVM Children's Hospital, also the vice chair for education in the Department of Pediatrics. Very interested in working with families affected by substance use disorder and has been with us again for before I came over, so had been here for a number of years, and again is very interested in collaborating with both the ICONS team and UVM Medical Center to improve care of opioid exposed newborns. And then today joining us as well, we have Daniel Beltry, who is a Master of Social Work and joining us from the Health Department. And apologies to Daniel that I was unable to locate your bio, which I know was here, but I will let you introduce yourself if that's okay. And again, apologies to everyone for my issues with Zoom today, but I am here in the background. And I will turn it over to our speakers.
I'll start with just a little bit of housekeeping. Please use the chat box. Keep yourself muted, and we do have captioning available at the bottom of your screen, and at the end of the presentation we'll have some evaluations. We really appreciate your feedback about our presentations and what you would like to hear covered in the future especially. Next slide. Our objectives today are to discuss the prevalence and epidemiologic trends of hepatitis C and HIV infections among pregnant persons in the U.S., and discuss new guidelines related to perinatal exposure to hepatitis C and HIV exposure and breastfeeding. Next slide. And I'll start us off with the updated CDC hepatitis C testing guidelines. Next slide. I have no disclosures. Next slide. So our goal with perinatal hepatitis C is really hepatitis C elimination. And the first step is proper identification of perinatally infected children so that we can connect them to appropriate treatment. Next step, or next slide. In terms of the goals, we really are focusing on, can others hear me? Yes, okay.
Yes.
So perinatal hepatitis C goals really focus on identification and connection. So we identify birth parents who are affected by hepatitis C, and then we identify at-risk infants, and then we identify affected infants, all the while connecting them to the appropriate next step in testing or in treatment. Next slide. And this is important because hepatitis C infections are increasing, especially in reproductive age adults. You can see from this graphic that goes from 2005 to 2020 that the most rapid rise, the top two lines, are in the 20 to 29 year age group and the 30 to 39 year age group. Next slide. And while the most common reported risk factor for acute infection in adults is injection drug use, the most common risk factor for children is perinatal exposure, and most acute infections are acquired perinatally. Next slide. In 2020, to increase identification during pregnancy, the CDC recommended hepatitis C testing during every pregnancy. This graphic looks from 2011 to 2021 in a private lab and shows testing rates in prenatal testing panels for hepatitis C. And you can see back in 2011, around 15% of patients had hepatitis C testing. And that has increased over time, in particular after the 2020 recommendation. This only goes until 2021, but I think we all hope that as of today in 2024, we're much closer to 100%. Next slide. When testing, we use a two-tiered testing approach in general. We start with a hepatitis C antibody test, which assesses for a response to a current or past infection. If this is non-reactive, no further testing is indicated. If this is reactive, the next step is to assess for the presence of the virus and assess for hepatitis C RNA. If this is not detected, there is no current hepatitis C infection. If this is detected, there is a current hepatitis C infection. Next slide. And we're going to focus in on the post-delivery phase, where we are identifying at-risk infants and connecting them to postnatal testing, as this is the aspect of care that the CDC changed their guidelines related to recently. Next slide. And we're going to look at this through the lens of a case. We have a 29-year-old woman who presents with no prenatal care and delivers an infant who appears term. Laboratory tests are notable for a toxicology test that is positive for fentanyl and a hepatitis C antibody test that is positive. There's no reflex RNA testing performed, and the mother leaves the hospital and cannot be found to discuss the results while the infant has gone into state custody. Next slide. For this case, what would you do next for the infant due to the hepatitis C result? Would you A, not recommend any infant testing because maternal hepatitis C is not confirmed by an RNA test? B, test infant hepatitis C RNA immediately and refer for follow-up with a specialist? C, recommend infant hepatitis C RNA at 2 to 6 months of age? Or D, recommend infant hepatitis C antibody at 18 months of age with reflex to RNA if appropriate? Next slide. The CDC recently reviewed evidence from 2001 to 2021, which will help us answer these questions. They concluded that infant testing is recommended for birth parents with a confirmed hepatitis C infection, meaning any hepatitis C RNA detected during a pregnancy, or for those with probable hepatitis C infection, meaning an antibody is reactive in pregnancy. However, there are no hepatitis C RNA results available. And so this case would fall into the category of probable hepatitis C infection. And the reason that the CDC recommended including this category and recommending infant testing is summarized in the table at the bottom of the screen. You can see that the prevalence of detectable hepatitis C RNA for birth parents who had a reactive antibody was 68%. So the vast majority would have a true hepatitis C case with detectable virus. Next slide. With this information, we can conclude that answer A is incorrect. We would recommend infant testing, as this is the case of probable hepatitis C. And the next question is, what is the appropriate timing of testing? Next slide. The graphic here is showing the titers that would be expected for an infant who contracted hepatitis C in the perinatal period. And what you can see going left to right is that in the first 2 months, it's really difficult to use laboratory studies to gather information about whether or not a baby has contracted hepatitis C. The hepatitis C RNA can have false positives and false negatives, and antibody tests are unreliable during that phase. Maternal antibodies have passed to the baby and would still be detectable, and infant antibodies are low and maybe undetectable. When you move to the right and look at the 2 to 17 month age range, you can see that the hepatitis C RNA should reliably be present. However, when you look at the antibody tests, you can see that maternal antibody is still waning and infant antibody is rising. And so a positive antibody result could be the result of either a maternal antibody circulating or an infant antibody circulating. So the antibody is unreliable, but the RNA test could be reliable and helpful. After 18 months of age, the maternal antibody will have waned and the infant antibody will be positive in most situations. So you could use a 2-tiered testing approach during this time period and start with an infant antibody test and then reflex to an RNA test if the infant antibody is positive. And we'll go to the next slide. So looking at this graphic has essentially told us that we would not want to test the infant immediately because tests in that time period are unreliable. And that leaves us with 2 final options. Do we recommend testing at 2 to 6 months of age with an RNA test and no antibody test? Or do we recommend testing at 18 months of age with an antibody test that would then reflex to RNA testing? Next slide. The CDC, first, prior guidelines have recommended that we test at 18 months of age, and that included the CDC. We could consider earlier testing at 2 to 6 months of age, but even if that were negative, testing at 18 months of age or greater was still recommended. Next slide. And this is in part because there are some differences between the 2 different testing approaches. If we are testing early on with RNA, it could detect an intermittent or transient viremia. 25 to 50% of infants who have detectable RNA will no longer have detectable RNA by age 4. In the past, it was also felt that the early RNA testing had low sensitivity with potential false negatives. So 18-month testing was also recommended. Over time, we've found that 18-month testing has a very high loss to follow-up in the time period between birth and 18 months of age. There are fewer well visits in the second year of life, and so there are fewer opportunities to identify infants who are eligible for this testing and may not have it ordered. Next slide. So when the CDC reviewed evidence from 2001 to 2021, one of the pieces of evidence that was quite striking was the high loss to follow-up. If you look at the table at the bottom of the screen, you can see that the proportion of at-risk infants who were ultimately tested in the 12 studies that they reviewed was only 30%. And that means that if the rate of perinatal transmission is 4.7%, as they found, that 70% of those infants were not tested and thus not diagnosed with hepatitis C. Next slide. The CDC also found that there was a recent large study that showed that 2 to 6 month RNA testing could be much more reliable than it was previously thought. It was found to be 100% sensitive and specific. And so 18-month testing may not be needed if 2 to 6 month RNA testing is negative. Overall, they concluded that testing at-risk infants at 2 to 6 months increases perinatally exposed infants who are diagnosed with hepatitis C and connected to appropriate care, and with cost saving on a population level. Next slide. So the CDC has changed their recommendation as of 2023, and the AAP supports this change as well and recommends it in the Red Book. They recommend that we test at-risk infants for hepatitis C RNA at 2 to 6 months. And if it is negative, we do not perform any further testing. Next slide. And so that leads to the answer to the question for the case, which is that we would recommend hepatitis C RNA at 2 to 6 months of age. Next slide. The CDC recommends that if the RNA is positive, that a patient be connected to appropriate subspecialty care. If the RNA is not detected in that time period, no further follow-up is needed. And if an infant is not tested in the 2 to 6 month time period, that testing would then be recommended at 7 to 17 months by RNA or 18 months or more by antibody with reflex to RNA. Next slide. So overall, the hope is that these changes will make that second step of identifying at-risk infants and connecting them to postnatal testing much more reliable, and ultimately identify more infants who have a hepatitis C infection and connect them to appropriate care. Next slide. So in summary, the CDC now recommends universal screening in every pregnancy for hepatitis C. And for infants born in the context of confirmed or probable hepatitis C, the CDC recommends hepatitis C RNA testing at 2 to 6 months of age. Overall, aiming to identify infants and connect them to the next step in testing and management. And I encourage anybody who has questions to put them in the chat. We are going to have a long Q&A period at the end of all 3 talks. And I will turn it over to Molly Rideout to share the CDC recommendations for HIV and breastfeeding.
Thank you, Adrienne. So we're going to shift gears a little bit and talk about newborn exposure to HIV and the new updated breastfeeding guidelines. Next slide. So I don't have any disclosures. I do have a couple of disclaimers. One is that language is changing. And so since we're talking about national guidelines, I'm using the terms that are used in them, which includes the term breastfeeding, acknowledging that chest feeding is also a term that's used, and pregnant or birthing person as well. And then just another disclaimer, I have a BCLC certification as lactation consultant, and I'm a pediatrician, but not an expert on HIV. But we do have specialists here. And then one last disclaimer is that some of the slides here were adapted from a national presentation by the hospital's team at Lurie Children's in Chicago and used with their permission. So we're going to start with this short video to set the stage. It's part of a national campaign to break the stigma of HIV infections.
I'm 27 and I was born with HIV. I was adopted at 6 weeks old. My adoptive parents did not find out that I was HIV positive until I was 3. My birth mother gave birth to another child And because she fit the high-risk categories, my birth mother and my sibling were tested, and they both came back as HIV positive, and that's when I was tested. I don't have a problem saying that I have AIDS, and I feel like there are individuals who have HIV or AIDS who feel like maybe they did something wrong or they feel ashamed to say and be public. So because I don't have a problem with saying that I have AIDS, because I know AIDS is something that happened to me but does not define me as a person, I felt like, okay, well, I'll use my face and my voice to help spread awareness to the fact that they do have HIV AIDS and they are members of the community. So anything that I can do to help others feel comfortable in their own skin when living with HIV or AIDS, I'll be a part of it. You can't contract HIV or AIDS through casual contact, so you have no reason to fear someone who has HIV AIDS. So just treat them as you would want to be treated. Maybe it was your mother, your brother, or your sister. Just treat them as a human being with dignity and respect. My parents didn't want me to feel like there was something wrong with me because I had AIDS, so we were always open, especially as a family. We would talk about HIV/AIDS at the dinner table. Whether I was in the doctor's office with them, I would always talk about having AIDS because they didn't want me to feel like there was anything that I did wrong as an individual. Life isn't over. You can do whatever you choose to do or whatever you put your mind to. So I just want individuals to realize that AIDS is not the end. Let's stop HIV together.
Get the facts, get tested, get involved.
Thanks, Angela. So next slide. So we're just going to go through some background data about HIV, and these are from CDC based on data from both from 2019 and 2022 that show similar trends. So for women with new HIV diagnoses, which are lower than the total, that's about 20% of total HIV infections are in women. Those in their 20s and 30s were the most commonly infected. Most new diagnoses among women were related to heterosexual contact, and only 10%, sorry, next slide. Yeah, so most were related to heterosexual contact. And then the next slide is only 10% of women who could benefit from pre-exposure prophylaxis for HIV were prescribed it. This was in 2019. That was compared in that same year to 23% for the overall US population. This has increased in the overall population to 36% in 22, and they didn't have the numbers for women, but much lower. So lack of awareness and lack of prescriptions is an issue. And then next slide. So there are racial differences in HIV infections. Black and African-American women are disproportionately affected. This is because there's more HIV in the communities where they are having sex. There have been multiple studies that have shown that Black women are not more likely to have unprotected sex, not more likely to have multiple partners or abuse substances than women of other racial and ethnic groups. And it's important, the important factors are really higher HIV in Black and African-American populations related to poverty, low education, low socioeconomics, and then all which originally have a root in structural racism. And next slide. So for people who are living with HIV who inject drugs or have injected drugs, there is also a difference by race, with white individuals affected more frequently. And next slide. So we also are going to go through a brief case. So there's a 30-year-old woman who's in her second pregnancy, which is a planned repeat C-section. She was diagnosed with HIV during her last pregnancy and has been taking antiretroviral therapy, or ART, consistently. She's had an undetectable viral load throughout her pregnancy, and the most recent test was 1 week ago. Her first child is HIV negative. She really wants to breastfeed this baby. And she has spoken with friends who have HIV who did breastfeed their babies, even though they were advised not to. And their babies didn't contract HIV. And next slide. So what will you tell her? And you can type into the chat. So will you say, A, will you tell her that breastfeeding is contraindicated since there's a risk of transmission? Will you encourage her to breastfeed since the risk of transmission is extremely low? Will you discuss the risks and benefits of breastfeeding with HIV to make an individualized decision? Okay, so yes. So next slide. So C sounds good. Thank you for typing into the chat. This is new. We're gonna, on the next slide, back up a little bit and talk about guidelines. So the ACOG in 2018 recommended screening all pregnant persons for HIV. And then if HIV is confirmed prior to delivery, it's essential to treat the newborn preferably within 6 hours. If HIV testing hasn't been done or is not available, it's important to test the birthing person. And then if they decline testing for whatever reason, the newborn should be tested. If the preliminary test is positive, the treatment should start as soon as possible, while awaiting the confirmatory test. So these are all recommendations or guidelines that are in place currently. Next slide. In terms of HIV and breastfeeding, there have been some changes in the CDC guidelines. These are the WHO guidelines that say since, they were started in 2010 and they've recommended breastfeeding as a preferred mode of infant feeding. There was a study and multiple studies showing that formula-fed infants had higher mortality globally. And this is thought to be related to risk of diarrheal illness and combined with malnutrition. So that's been the recommendation for quite a long time. They also recommended against combination feeding, which is formula and breastfeeding, doing some of each. And the physiology behind that is just increase in inflammation in the GI tract and with increased transmission. And next slide. So the CDC, on the other hand, recommended against breastfeeding for women or pregnant breastfeeding parents with HIV. These guidelines started in 1985, so they're quite old, almost 40 years old. And the assumption has been made that the risk of transmission of HIV is higher than the risk of mortality from diarrheal disease or malnutrition. There's been a lot of progress in antiretroviral therapy and prevention of mother-to-child transmission of HIV over the last several decades. So that was what initiated kind of rethinking this policy. And next slide. So there's quite a few reasons that birthing parents would be motivated to breastfeed. The indisputable health benefits of breastfeeding, benefits of bonding. Another important thing to think about is in a culture it predominantly, culturally, it's breastfeeding is the norm. If a birthing parent decides not to breastfeed, she might be inadvertently disclosing her HIV status, which has a lot of stigma, may have a lot of stigma. And also barriers to formula access definitely exist in this country. So it's important to consider all of this. The human and emotional side of this decision is quite large. And I think that's well reflected in this quote. In abstaining from breastfeeding, participants felt an acute sense of personal loss, often crying when discussing their decision and describing themselves as sad, unhappy, and devastated. Also, if birthing parents are going to breastfeed anyway, it would be better to have an open conversation about it and be aware of what the risk factors are so that appropriate screening can take place and just providing optimal care for the baby. And next slide. So welcome to the new guidelines. So the CDC came out with guidelines in January 2023, and then that was followed by AAP in June of 2024. Next slide. So the new guideline involves shared decision-making with parents. And they say that sustained viral suppression during pregnancy and delivery decreases the risk of transmission, not to zero, but to extremely low. And also that if a birthing parent is not on ART or the viral load is not suppressed over a sustained period of time in the third trimester, that formula or DHM should be used. Donor formula or donor human milk should be used. And the next slide. AAP says essentially the same. So there needs to be a sustained suppression with a negative viral load of less than 50 copies per ml within 4 weeks of delivery and after 36 weeks. So next slide. There's certain practices that can increase transmission. So it is important for birthing parents who decide to breastfeed, if they have HIV, for them to know that it's important to not combination feed, like we mentioned before. Just they can cause inflammation of the GI tract and increase the transmission. There are a couple of exceptions to this, which we'll talk a little bit about. One is if donor human milk isn't available and there's delayed lactogenesis, so if milk is taking a really long time to come in and the baby has excessive weight loss, it is acceptable to use formula for a brief time. Again, this would be shared decision-making with the parents, knowing that the risk isn't zero. Also, it's important to try and avoid mastitis. If a pregnant person has mastitis, there is increased viral load in the breast milk on the affected breast, again, related to inflammation. Also, there is increased viral load if there's milk stasis. So you want to avoid stasis in terms of emptying breast and at the same time avoid overpumping, which can cause inflammation as well. So there's kind of a fine balance, and just important to pay attention to just overall the principle of inflammation in the breast that can cause increased viral load in the breast milk. Also related is weaning. So if a pregnant or lactating person is weaning, important to wean slowly to minimize that inflammation. This is another time period that might necessitate a brief use of formula if donor milk is not available for as the mother is weaning down or the birthing person. Next slide. So super important that if the birthing parent with HIV is not on ART or does not have a sustained suppressed viral load, they should not breastfeed or give express breast milk. And this is universally accepted by all of the guidelines. So back to our case, next slide. So the woman had a planned C-section. The C-section was complicated by an intrapartum hemorrhage. So the mother has decided to breastfeed. The baby latches really well. Her milk isn't in. The baby appropriately started on zidovudine shortly after delivery. At 48 hours, the baby has lost quite a bit of birth weight, 9%. The mother isn't able to express colostrum. The lactation consultant is involved, which is important. So what should we do? So probably the postpartum hemorrhages leading to some delayed lactogenesis. So next slide. So what will you do? So will you tell her to pump every 2 to 3 hours and give the baby any of the express breast milk? Will you supplement with formula until her milk comes in? Will you supplement with donor milk until her milk comes in? So just type into the chat what you think. It's a little tricky, right? So next slide. We would recommend see if donor milk is available. it's not wrong for her to be pumping and stimulating her milk supply. It's just if she is overdoing the pumping, it could cause some inflammation in her breast and in the expressed milk. So pumping maybe not quite every 2 to 3 hours, maybe just kind of, and hand expression does not cause inflammation, so that definitely is great. So a little bit of nuance there. Next slide. So shared decision making. If there's a sustained undetectable viral load, should support women and pregnant persons in this decision, birthing parents. Individuals who decide to formula feed should also be supported in this decision. Also having conversations to find out what the perceived barriers to breastfeeding are, but supporting it. And then also CPS should not be called. I mean, maybe that seems really obvious, but it's not completely obvious in the US, so it's not appropriate. And next slide. Okay, so updating on the case. So the baby received donor milk supplements in the hospital. Social work and lactation work together to secure donor milk supplements at discharge. She pumps regularly and her milk comes in on day 5. And the baby has follow-up testing that's negative at 2 and 4. I think that should be months. And next slide. So in summary, all the places, AAP, CDC, WHO, all support shared decision-making surrounding breastfeeding for persons living with HIV. HIV transmission through breast milk is low if there's a sustained and suppressed viral load. Inflammation of the breast or milk stasis can lead to increased viral load in the milk, and mixed feeding is correlated with increased risk of transmission. Also super important I put a plug in for having lactation consultants be involved with all pregnant and birthing persons with HIV to give maximal support to avoid some of the breastfeeding problems as much as possible. There is a webinar, I'll put the link in the chat, 2 little 6-minute videos that are great to kind of explain some of these new guidelines. And then I'm gonna hand it over to Daniel Daltrey, is the Infectious Disease Program Manager at the Vermont Department of Health. He works within the Laboratory Sciences and Infectious Disease Program since 2006, where he's been responsible for the oversight of HIV, STI, and Hepatitis C care, prevention, and surveillance. In addition to his work locally, he serves on the board of the National Coalition of STD Directors. Welcome, Daniel.
Great. Thanks for having me. Hope everyone can hear me. Glad I am going last. I certainly have been learning a lot here, and I hope you stay awake because we have a very important question and answer to follow. What I am intending to cover here is just a quick cursory glance, about 8 core content slides. Want to let you know a little bit about what the data looks like here in Vermont. We've seen some national numbers and figures. Just want to tell you a little bit about what we see here in Vermont at the Vermont Department of Health. And of course, the numbers that I present out do come with limitations. I will share those at the end, but based upon what we do know, I am going to share, or based upon what we see, I'm going to report out what that is to you. Again, with a caveat of all data does come with limitations. I also want to put a plug out there. These numbers, while any individual impacted is a concern, I want to say Vermont stands in a really great place because of the practitioners that we have in Vermont providing comprehensive care and access to healthcare that individuals have where they feel inclined and able to access healthcare. Vermont is in a really great place because of Vermonters seeking, accessing, and feeling welcomed by healthcare, and then the comprehensive healthcare that is given when it is given. So thank you to those of you that are practitioners here or public health educators. It really does go a long way. With that being said, I want to jump into the data. Next slide, please. So I have no relevant financial disclosures. I want to talk a little bit first about HIV, and then we'll move over to hepatitis C. So these are our numbers. As of 2023, we have a total of 731 individuals living with HIV in Vermont that are known to be living with HIV in Vermont. Case rate is fairly low. One of the things that if we look at this graph here, I just want to show you an average of how many cases that are being newly diagnosed in Vermont each year. As you see in 2017, we had a little bit of a spike. Technically, we were calling it an outbreak. Through community partnership, which includes community providers, social service providers, but also medical providers, we were able to engage vulnerable populations and get individuals in to find out their HIV status and ultimately come into care. What you don't see behind this number or in following slides is I do want to point out, while we have 731 individuals living with HIV, just over 40 individuals actually have a detectable viral load, which is when somebody is able to sexually transmit the virus. It's pretty incredible that in Vermont, those engaged in care, living with HIV, we have just over 40 individuals with a non-suppressed viral load, working all the time to do what we can to help all maximize healthcare, but unfortunately, not everyone does have a suppressed viral load. Next slide. So if we do a breakdown in terms of looking at the risk or the gender first and foremost, over just 17%, 120 individuals are identified as female, meaning here assigned female at birth and still identifying as female. So 120 females that are living with HIV. Of those individuals, 49 are between the ages of 15 and 49, childbearing age. 2 individuals we have identified in 2022 to 23 that were perinatally exposed. Both mothers were viral load suppressed at the time, so we did not see newborn acquisition. We do have pediatric cases in the recent years. Those individuals were diagnosed with HIV prior to coming to Vermont. So just before we go to the next slide, I want to point out here, Vermont is a little bit different than the national numbers, as well as trends. We are still predominantly male. Yes, it does still happen to assign female at births, though, as well here in Vermont. Next slide. Hepatitis C. So our data, hepatitis C is variable. Case definitions have evolved through the years. I've been in this program since 2006, and looking at our surveillance and ability on hepatitis C has changed and evolved in a really good way over the years. Our accounting of cases has the case definition set forth by the CDC. Case definition for surveillance has changed, has evolved, has become more specific, which is part of the reason why you see the numbers there dropping down. So we're leveling out in terms of probably getting a more accurate snapshot of who is truly living with either acute or chronic hepatitis C. There used to be a bit of a wider net in terms of what we were counting for hepatitis C. We weren't able to look at the data as closely, but we also didn't have reporting mechanisms such as negative viral loads to compare and contrast to a case that is newly reported to us. So I wouldn't say when you look at the peak of 900 and some folks living with hepatitis C to 349, we can't necessarily say that it is a true decrease. What I can tell you is that the definition is more specific. And I think we have a better, I was almost going to say a realer real I'm so eloquent sometimes. We have a more accurate depiction of individuals living with hepatitis C that have tested positive here in Vermont when we look at the latest numbers. But of course, this is only as good as the individuals that come in for testing. And some of our services are maybe hard to reach for those that are most in need of them. So this snapshot is more accurate in terms of who has tested positive and who truly has it, but it's still not all the individuals that are living with it that know it. So little parsing out there, if you will. Next slide. So among hepatitis C, again, looking at genders, and please footnote, when we are talking about male and female, we're talking about assigned male at birth, assigned female at birth here. We are not able with our surveillance system to track trans-identified communities within our data at this point. Hopefully that is something that will evolve. The hepatitis C surveillance system doesn't account for that right now. So when we are talking about female here, we are talking about assigned female at birth. Among those individuals, what we see is about 41% overall from 2013 to 23 were diagnosed with hepatitis C, right? Of those individuals, the majority, 73%, were of childbearing age. Next slide. So this is the part that we want to make sure we talk about some of the limitations. So while we have that data in terms of knowing individuals that were of childbearing age through the years, we also do realize that we could be missing some individuals. We don't do a full case investigation like we do for other infections, chlamydia, gonorrhea, syphilis, HIV, oh my. On hepatitis C, the cases are large enough right now that we aren't doing full case investigations, but inspired by some of the scope of work that's changing at CDC, looking at needs in Vermont, especially in light of this consortium here, we are looking at ways in which to modify our operations, meaning when we do get individuals that are newly reported to us as having chronic or acute hepatitis C and they are in childbearing years, this could be a case that we prioritize to do a more fuller investigation, calling the medical provider, finding out what is going on, trying to understand a little bit more about the risk for the birthing parent, for the newborn, as well as maybe some good old-fashioned contact tracing thrown in if we are able to interview the individual as well. But as it stands right now, we don't have a full case investigation. We are just going based upon serology that's reported to the Department of Health. Next limitation, surveillance methods have changed over time. Oh, sorry, back. As I talked about, as I was rambling about a little bit earlier, our case definitions have evolved. They've gotten tighter and more specific. So we are better able to identify acute now than we previously were. We have modified some of the reporting laws to help us be able to understand better a fuller picture of an individual's health, mainly by tracking negative viral loads. That really has been a significant addition for us in helping us to identify acute cases. And of course, that leaves out historically, we've had a lack of negative RNAs, so we can't truly tell. Right now, unfortunately, we do get individuals, we knew of them in 2009, 2008, then nothing, and then suddenly again. Currently, we do not have the capacity to see about whether or not this is a new infection or a residual infection. So some of these numbers might not be accounting, we might not be accounting for acute new infections if somebody had a history or chronic infection with somebody that might have had a history. So some of the limitations that we look at right now. Next slide. And so when we also do kind of a birth match, we do a birth registry match. There are limitations here, but sorry, I'm a broken record about limitations. But I do want to highlight here that looking at from 2020 to 2024, we saw 501 assigned female at birth that were of childbearing age diagnosed with hepatitis C. Among those individuals, we had 84 individuals that were a match with our birth registry. Keeping in mind when we do that match, though, names could change. A last name could change. And so if that last name is changed in the birth registry between what was reported to us, it might not align. We might not see that individual. But so of the 84 individuals with HCV and birth registry during that 4-year period, if you could see the small print, it simply states that we had five of those individuals were multiple births, had multiple births through that time period of 2020 to 2024. Of the 84 births that happened, 42 had a detectable viral load during pregnancy. Unfortunately, perinatal exposed infants who were properly tested, we are not able to identify because what I was talking about before with our full case investigation. Next slide. So here we go, limitations. I think that's what you might all be calling me after this presentation, Daniel Limitation Daltrey. But I do want to highlight here some of those limitations that I was talking about with the birth registry match. Differences in date of birth, we won't be able to pick that up. Sometimes that happens, user error. When I in the two systems, therefore they don't connect. Additionally, the birthing occurs during this time period, the analysis, but birthing persons diagnosed before 2020 were not captured. So we might be missing a bit of the populations. Births among people who are diagnosed with HCV in Vermont, some of these individuals have moved out of the state. So we can't do a capture recapture in terms of that information. And I think I'm getting the hook. We're about to hit the hour. I know your hour is important. So next slide, I think I'm done. Yes. All right. So with 3 minutes, I turn it back over. Questions and answers. Here's some resources, though. We have live experts that can talk about treatment in hepatitis C as well as HIV. So I'm going to pause and mute myself.
Thank you so much. So we do have Dr. Ben Lee from Pediatric Infectious Disease and Dr. Nina Guchowski from Pediatric Gastroenterology here. And I do see one question in the chat that looks like it would best be answered by Dr. Guchowski. It is the question about whether the earlier detection of hepatitis C would lead to earlier treatment and what is treatment?
Yes, very good question. So interestingly, earlier detection as of where we stand right now does not lead to earlier treatment, with the exception of I have had patients present later in life where they were missed in the 18-month, when the recommendation was to test at 18 months, they weren't tested until much later in life. So those people very likely would have been treated earlier. That said, the infants diagnosed now as early as 2 months old still would not qualify for the treatments we have available until 3 years of age. However, it does make sense, and I think Dr. Lee would agree, to refer to one of our subspecialty clinics as soon as possible to engage in the conversation about the natural history of the disease, prognosis, and treatment regimens. We're very fortunate to live in this era where hepatitis C is now curable with oral medications called the direct-acting antiviral medications, and the pan-genotypic regimens available are oral medications as either tablets or pellets for kids who can't swallow pills over the course of 8 to 12 weeks. And as long as there is good adherence, in general, we say then it is a curable disease. And if the monitoring, if the Hep C RNA is not detectable 12 weeks after completion of therapy, that's called a sustained viral response, then the patient is determined to be cured of hepatitis C. And the earlier you treat it, the less likely it is to have any long-term sequelae. I'll be respectful of time here. I'll stop there. But as of now, we still would not initiate treatment until 3 years old, but it makes sense to engage with subspecialty care beforehand.
Thank you so much. And I know that is a whole separate webinar, or probably 5 of them. And I'd like to ask a similar question to Dr. Lee. Could you describe what happens if a newborn tests positive for HIV in terms of treatment and ongoing testing and management?
Yeah, I mean, I think so. There might be 2 scenarios where a young infant test positive, and the first is if they're identified as high risk, during prenatal care or during the course of delivery, where we know the mother's not virally suppressed. Those babies who are identified in the immediate perinatal period or prenatal period as likely being high risk at the time of delivery will get empirically started on a 3-drug regimen as preventive therapy versus the single monotherapy with zidovudine, which is given as prophylaxis in low risk scenarios. And in that setting, that actually is effective therapy that they'd be starting right from the get-go. So that would just be continued. The other setting is if for whatever reason, either testing did not happen or the child's in an hospital, various scenarios where you may get a later diagnosis. In fact, it would likely be still that same initial regimen that we would use for the 3-drug preventive therapy at the time of birth for those who are identified early as being higher risk. Any new diagnosis of potential new diagnosis of HIV, you would want to confirm with the second test. But then at that point, usually the typical regimen is, there is a sort of expected decline in the viral load with the initiation of therapy. But the management of the infected child at minimum tends to be the general formula is ongoing triple drug therapy with monitoring roughly every 3 months at minimum early on until we can achieve viral load suppression. And then for families with good adherence and stably suppressed viral loads, that can tend to relax a little bit. But of course, as one challenge ends, a new one begins. So as the child is growing and developing, it requires a lot of monitoring for making sure we're doing dose adjustments, potentially switching therapies depending on how they're tolerating toxicities, that sort of thing. And then, of course, the adolescence that's a whole nother discussion. So this is just sort of in the early life period that I'm referring to.
Thank you so much. I know there's so much more that we could talk about, and I wish we had another hour. I really want to say thank you to everybody who joined today, and especially to Dr. Gluchevsky and Dr. Lee for being available to share their expertise with us. Please complete the evaluation. The link is on the screen. And if you do have any follow-up questions, presenters or experts who have been available on the call, please feel free to put them in the chat or email them to any member of the ICON team. Again, thank you so much.